thank you for being here with us. Your presentation is about integration. I understand so.
Yes.
Welcome.
So thank you very much for organising this link that allows me to be in the conference. I was hoping to be there in person, but events got in the way, or rather a bicycle got in the way, and I'm stuck here at home. You asked me to talk about the British experience of service integration, particularly for older people, and I'm going to do that, but you have to understand in England the word integration has many meanings. It can mean multidisciplinary working or collaborative working, and it can mean at the opposite end of the spectrum, the reorganization of services to create new delivery structures. And I'm going to, when I talk about integration, it can be any of those things. I'll try and give examples as we go along. I think the first point to make about integration as we experience it in the National Health Service in Great Britain is that it's driven by cost containment needs. So the wish to work in simpler, better and more cost-effective ways is really a financial wish. But the quality, the issue of quality of care is introduced into that by having a powerful patient and public involvement process. So that is vital to make sure that integration, when it occurs, is not just about saving money, but it's about working more effectively and more cost effectively. Now, Holland is the same as England in the sense that you have a lot of experience of integrated care, and it's very good, as is ours. Think about the orthopedic surgeon and the rehabilitation team as an example of good quality integrated care. Think about maternity services, pregnancy care, as an example of good quality integrated care. These examples all depend upon long-standing mutual trust between different disciplines that believe in core working, as in collaborative working, as a core business for their activity. They are, of course, all about short-term needs. The person with a fractured hip who has a hip replacement and then rehabilitation has a short-term need which can be met. The pregnant woman has a short-term need that can be met. Our problem is a problem of an aging society and of the oldest old with complex needs and unstable disabilities whose needs are difficult to meet and that are not short-term, they're much longer term, and of course they're progressive. They get more intense as time passes. And for that group of people, we see from all of the efforts to integrate care for older people, how difficult it can be. First of all, the clinical problem to be solved by integrated care has to be very carefully defined. You cannot integrate all services for all people. It simply doesn't make sense. It has to be a specific kind of collaborative working for a specific set of tasks. The second point there is that integration costs before it pays. That is, that whoever is interested in reorganizing services for an aging population has to accept that investments of large sums of money will be needed, often for quite significant periods of time, so that services can run in parallel until the old system hands over to the new. And of course, if I am the person organizing the integration, then I likely decide what integration means and who is inside it and who is outside it. You must remember that integration is not always good for everybody. My integration may be your disintegration, and there may be resistance to change because of that. So I think at the moment, the attitude in Britain about dealing with the problems of an aging society is that we don't need lots of little studies anymore to show us how to do it. We need a approach which covers the whole system of care for older people with complex needs. That system would include their background, the circumstances in which they live. It would include the responses to them if their health deteriorates suddenly or slowly. And of course, it would include the ways in which hospitals in particular are organized to work with this group of people. So the background, for example, would include things like the amount of resource and effort that goes into promoting self-care and the health of family carers. Or, as another example, the ways in which information and communication technology are used to enable people to stay in their own homes for as long as possible and to support their family members who are caring for them. If specialist intervention is required because of a change in health status, then the question arises, before you get admitted to hospital, is it possible to manage your problem in a better setting than a hospital? Hospitals are relatively dangerous places for older people with complex needs. And to know that, we have to know that there is some awareness in the community of who's at risk. Can we identify at least the majority of people who are likely to be at risk of sudden deterioration in their health and take some proactive steps to prevent that deterioration if we can? And if that's not preventable, do we have the multidisciplinary teams in place that can provide a rapid response to individuals' needs? And by rapid, I mean within hours, not within days or weeks. If you think about the hospital side of this whole system, then can we honestly say in our hospitals we have the expertise to apply comprehensive geriatric assessment methods very early on in the patient's stay, ideally within the accident and emergency department before actual admission to hospital has occurred? Is that comprehensive geriatric assessment trusted by all the disciplines, and do we put in place routinely discharge processes the moment the individual is admitted to hospital? So I think our emphasis is on whole systems approaches now, not on pilotitis, not on the reproduction of large numbers of small-scale studies that don't really change anything very much. Now, that's a very rapid run through what I think we're thinking about in the UK. I appreciate I've done it very quickly. If you want to exchange emails with me about it, I'm sure the organisers will provide you with my email address. And once again, thank you for organising this link.
Well, Professor, I read your presentation, and one of your statements is the one who integrates calls the tune. You said that. I think we agree on that. But how do we start? Did you hear my question?
I'm losing the link here, I'm afraid. I miss it. Some words were missing. I'm sorry.
Are we still in contact? Yes? Okay. I repeat the question. I read your presentation, and one of your statements was the one who integrates calls the tune. Yes?
That's
and I
right.
think we agree on this. But how do we start?
Yes, this is one of Lutz's rules from the United States, the 5 rules of integration, from summing up the experience of American attempts to integrate services. And an example of it would be from the United Kingdom, that if palliative care teams are organised under nursing leadership, they function very differently from palliative care teams organised under medical leadership. They have a different approach to care, and I think probably provide different outcomes for patients. That's just because the two disciplines have different views about what priority tasks to deal with first.
Well, I thank you again, and we wish you all the best with uni.
Thank you.
Thank you very much.
Goodbye.